So my name is Gary Massey with the Chancellor Collaborative Resource Group, CCR. We are here to give an update on the Medicaid transformation. And my background, just to give a little more clarity there around the role that I play with CCR as well as in this presentation, is more from a financial perspective. CPA by profession, been involved with healthcare organizations going on 40 plus years now. That's why the gray hair. But in any case, that whole history of working with Medicare and Medicaid programs and having been involved here with APNC / Governor's Institute for a number of years in that context of trying to help organizations that are looking at Medicaid transformation from a financial perspective and some of the things that are challenging those organizations. We're going to talk about some of that in that context today. But before we go too far, my colleague here.
My name is Tara Larson, and I have pretty extensive experience here in North Carolina in our public system. My background is I started out as a clinician and actually worked in the state facilities for a while, and then worked my way up, if you want to call it that way, through the system. Was Deputy Director for the Division of Mental Health, Developmental Disabilities, and Substance Use Services for quite some years. And for some reason they said, hey, Tara, you want to go help run Medicaid? And so I got moved over to the Medicaid agency since I was the liaison in DMH for all the Medicaid work. So went over to Medicaid and was the clinical director, deputy director, and the interim director on a few occasions. And retired from state, so I'm here to tell you there is life after retirement, and you can, several of us at CCR talk about we have a 12-step program for retired state employees, so we have fun. We have a fun time doing what we love, and that is healthcare, human services, and supporting people that we all feel so strongly about. And we also spend so much of our passion with supporting providers like yourselves on how to put services and supports in place to assist people. So with that, we're here to talk about Medicaid transformation, which I know none of you have any concerns about and don't have any questions about. And we're going to try to make it as simple as possible, and I think it's important that we remember that today is March 29th, because on April 5th, or April 6th, or April 1st, or there are going to be some updates. So it's going to be important to know, as of today, this is what we know. So, Gary.
Yes. So objectives for today. As we said, we're going to talk about kind of the components for the standard and for the tailored plan as laid out in the 1115 waiver. We're going to try to identify some key programmatic business requirements that providers, organizations like yours need to understand, develop, implement. We're going to challenge you as to how you bring together kind of a collaborative group among yourselves even to figure that out as well. Impact potentially on individuals being served, anticipated timelines for outreach. Again, we've got some information in this that really tries to lay out how this is all going to kind of unfold from what Tara just said, and in the context of this is as of today, this is what we know. Next week there may be some other changes that will impact. And of course talk about opportunities for the provider organizations and how you still have a voice especially in the implementation of what's going on. So we're going to go through those as kind of our learning objectives today. But let's kind of start from looking at this thing. In any case, if we start from kind of some fundamentals here around the impact of health insurance on the holistic kind of outcome for an individual, and if we kind of put that individual in the center here and their individual outcomes, and then all of the pieces around them that have impact on their life, their health, we know that having health insurance, or in the context of what we're going to be talking about today, Medicaid as that health plan, makes a huge difference in what's going on with that individual. And of course, one of the other pieces that is so important to this whole transformation and the whole purpose around going to the 1115 is that latitude that we're now beginning to see in the context of the money they've invested in or will be investing in social determinants of health as well. And we know those have huge impact, environmental impact, impacts around the behaviors, et cetera. So that piece we'll talk about some as well.
So Gary, I think it's also important, as especially you as providers of substance use disorders, we know that substance use is a family disease. It's a family system. And so when you're only looking at the individual and you're looking at getting that person in sobriety or in recovery, many times we've not been able to address all those issues of resiliency or those pieces of stable housing or dealing with underlying factors such as personal violence or lack of employment or those aspects that, or intergenerational trauma. You know, sexual abuse as a child. All of those pieces have now started really surfacing to the point of, hey, if I'm appearing for treatment for substance use, have I also had an ACEs done? Have I also looked at those health risk assessments and social determinants, so that I'm looking at social support, I'm looking at family function. If I go back into that same environment, what is it going to look like and what is it going to do about my success for recovery and my ability to build those resiliency skills? And then with, you know, healthy behaviors, the actual care process and the health status. One of the things that the 1115 emphasizes, and I think people kind of like pass it over, and we talk about Medicaid transformation is about whole person care. I mean, how many times have we heard that? And many people in our world jump straight to, oh, that means primary care integration with behavioral health. That's that. That's just a small piece of that. It's about whole person everything. It's not only about the primary care and the medical side, it's the social determinants and it's those other all those other factors. You guys know better than anybody on what happens if you've got somebody in recovery and you're not taking care of all those other factors, or you're not dealing with the diabetes or the high blood pressure. And we know long-term substance use disorders is automatically going to exacerbate chronic conditions, right? Chronic disease. So think about that in whole person care, because when we talk about value-based purchasing, that's where it's going to get us when we start thinking about that holistically. Okay?
And clearly the piece Tara just touched on is, again, the parity, the whole physical health being encompassing into the behavioral health. That's the direction that we need to be headed in. So what do we know about the Medicaid transformation? We have what we call the standard plan, and we're going to talk about timelines for the startup of standard plan. We've got tailored plan, which is a whole population that's still going to be into its own acute care needs, and we're going to get into more definition around that. We also understand that fee-for-service for some individuals is still going to be the choice of how that population is going to continue to be served. And we also have in the western part of the state members of the Eastern Band and the Cherokee Indian that are going to be formed into what we call in the tribal option. So that's another carve-out piece that's going on under the 1915 BC waivers.
So that actually will be one of the, that's not part of the BC waiver, that's actually part of the a managed care, tribal option, 1115, primary care case management. So
Right.
I probably need to bring that slide a little bit out.
Yeah, we need to refresh that, don't we?
Yeah.
All right. So the legislation that was passed and then is being implemented divided the state up with regionals. We've got a statewide group. We're going to talk more about, show you the map on that. It allows for these tailored plans that are currently or will continue to be under the LME MCOs. We'll talk more around that piece and how that is going to evolve to where those will be starting more out towards 2021. But again, both plans are managing some of the issues that we're talking about with substance use services plus other Medicaid benefits. There are some exceptions. We would highlight here about dental services, the LEAs being left. PACE program, interestingly enough, is its own bundled, if you're not familiar with that program of all-inclusive care for the frail elderly. It too is a similar concept around holistic care. I mean, they're being paid under a managed care plan of its own, that they're getting dollars from Medicaid, they're getting dollars from Medicare, and they're responsible for the care of that individual, whether it's physical, social. I mean, there's a lot of other things that are bundled in. It's got some very positive opportunities within that.
So as we talk about standard plan and tailored plan, conceptually we need you to think two things. One is whole person care in the definition that we just talked about, not the definition of primary care integrated. That's just a one component. The second thing is, as we move forward, think about it in terms of eligibility, both on service access, what services are needed, but also there'll be characteristics or diagnoses that actually get you into a standard plan or a tailored plan. So, and we'll go over more details, but just to kind of set the stage. When we talk about some things will stay in fee-for-service, these things stay in fee-for-service. Dental benefit. So even though Tara may be in a standard plan, my dental services are going to be continuing to be provided under fee-for-service. LEAs, or local education agencies, that's the schools. Schools bill Medicaid. So schools can bill for OT, PT, speech, psychology, case management, nursing services. They will stay under fee-for-service and they won't be included under managed care. So a standard plan right now won't manage dental, they won't manage LEA billing, and they won't manage PACE, which is Program for All-Inclusive for Care for Elderly and frail and elderly individuals. Okay? Does that make sense? Clear as mud? Yeah, cool.
So the PHPs, or the prepaid health plans, for the North Carolina Whoa, what happened there?
You fast forward.
Yeah, we jumped ahead. In any case, when they went through the whole process of assessing the RFP responses, we had 4 organizations that were selected for statewide coverage. AmeriHealth, Blue Cross and Blue Shield, United, WellCare. We also had one organization that was connected with the physicians and operated with Centene, who now we understand Centene is trying to buy out WellCare. So there's an interesting dynamics already unfolding within these organizations. But this group went for a provider-led entity, which in a provider-led entity, we're talking about an organization that's 51% controlled by physicians. Mm-hmm. So there,
or other practitioners, not just physicians.
Right. So it's this group put together with the medical society and the old, what am I trying to think, CCNC group. They and Centene, they got awarded 2 regions. I think they wanted a much broader geography. And they've actually are looking at some kind of appeal, if I understand correctly, to get that bigger geography, because they've got a lot of their physician members are in the other regions. the other 4 regions. And there has been an appeal filed by another group that was backed by the hospitals. NC POPS, I think, is the acronym or name they went by. That was made up of about 7 to 8 hospital systems across the state. They did not get awarded anything, but they have filed an appeal for that.
So that's not unusual for Medicaid, for an appeal to be filed. I've been in this world, in the Medicaid space, like 30 plus years, and I've never known a managed care RFP to not be appealed. Because in North Carolina, you're talking about $14 billion program. This is money. This is money. So the Secretary's position is that they are continuing to move forward on the same timeline. If the judge comes in and says we need to slow down or issues a temporary restraining order or whatever, then that we'll know about that. But right now, start dates, implementation dates, everything's moving forward as if no appeal had been filed. Okay?
So these are the 6 regions across the state. Over here in the east, Region 6. Over here in the west, starting with Region 1. We talked about the 2 and 4 that are starting in November. So right down here, November 2019. And then we've got the other 4 regions rolling out as of February 2020. So those are kind of the target dates of when things will be starting. We've got some more information on subsequent slides about various activities that are going on, but just to give you some visual of how they're breaking them down, and of course grouped by counties across the 6 regions.
So you are currently used to dealing with LME MCOs that are in catchment areas, and there are 7 LME MCOs. And have you noticed that there are these 6 health regions don't match the 7 LME catchment areas? Trauma number 1. And that we'll be hearing more about that over the next few months, because there are discussions going on what needs to change to better align, or if they are not aligned, what does that mean for you? Now, why is that also important? Because standard plans, those 4 standard plans that Gary just talked about, WellCare United, Blue Cross Blue Shield, and AmeriHealth Caritas are statewide. So guess what? If you join the WellCare network, you are in WellCare network statewide. So it's not just about being able to provide services because I'm in the 1915B in the Trillium catchment area. Now, that doesn't mean you still have to deal with credentialing and all those other pieces, but objective about opportunity, who do I need to serve and where do I need to go? They only have the Medicaid dollars. They do not have the state IPRS single stream dollars. All right? Something to think about, and we'll spend some more time here in a minute.
So I think this is where you...
So if we go back to the standard plan, just back up a sec. All right, so here is where we're going in terms of the region. And again, you're used to pretty much all Medicaid services being under the 1915 BC. There's a few exceptions on some E&M codes with primary care docs, but basically you're here. As of November 1st, 2019, for Regions 2 and Regions 4, so that would be part of the Cardinal catchment area, part of the Via catchment area, part of the Alliance catchment area. Those services can now be accessed outside of the 1915B waiver.
This is just another slide to give you more clarity around where the counties are that are broken down by the 6 regions. So we've got that slide that and we also wanted to take you into this piece right here, is where the piece I was anxious about most. Because this gives you that timeline that for regions 2 and 4, which are the first ones to go live, November 2019, you can see kind of the things that they're working on. The PHPs are giving information to the folks that are being the enrollment brokers, the ones that are going to be reaching out to the Medicaid members, trying to help them understand their choices. They're getting some marketing materials that are going to be shared from the PHPs to the enrollment broker. As we move down the line, you can see the directories being developed that for each of the PHPs that they're going to be sharing, again, with members. We've got letters, communication going out to those Medicaid beneficiaries, explaining what's happening. One of the things that we've been talking with organizations about, if you're involved on a fairly regular basis now with Medicaid beneficiaries coming into your service, you're making contacts with them, those individuals need to hear from you as to some of this activity as well. Because they're going to have lots of questions. And some of them are just going to be totally confused. But the more you can help them, and it's also helpful to you as well. It's a win-win for you because those beneficiaries are going to listen to what you're saying and hopefully are going to stay within your service or be interested in your services being provided to them through the PHPs, the PLEs, etc. But in any case, in all of this June, July, when they start July into September with the enrollments, more information, not less, is going to probably be advantageous with Medicaid members. That's going to be going on. Those that choose not to make their own selection, there's going to be an auto-select process at some point down the line as well.
Actually, they haven't selected by September of 13th.
Right.
They will be assigned to a standard plan if they meet the criteria.
There's going to be cards, new Medicaid cards going out to these members explaining who they're now enrolled with as their PHP or the PLE, as the case may be. What else are we talking about?
So for you as a provider, several things that I would like just put on your radar. One is between now, well actually, and this time period, PHPs are building out their provider networks, okay? And my recommendation, our recommendation to providers is you want to sign up with every PHP there is, every PLE, all 5 plans. Because remember, in a minute, you're going to see why some of that, those services that you're used to only being able to get in the BC waiver, if the person is in basic outpatient treatment for substance use and they haven't had substance use admissions, they haven't had some of these other pieces, they don't stay in the BC waiver. They're coming out of that BC waiver and they're going into the standard plan. So you will no longer get paid for that individual by an LME MCO. State funds are going to continue, but it's a Medicaid recipient. So you're going to want, so if you haven't gotten contacted yet by a PHP for a contract, now you have choice. You may say, I don't want to deal with that. That's a business decision you need to make. Down here, your front office your front desk offices are used to seeing Medicaid cards issued by the state. Okay? Those Medicaid cards for standard plan will now be issued by the PHP. So you'll get a card. Now we don't know what that card's going to look like, but it'll be a United card, it'll be a WellCare card, it'll be a AmeriHealth card. It will not be the state-issued DHHS card. Okay? So you may want to make sure your front office staff know that. They're going to be getting files, daily dumps on data from who's enrolled with whom and which providers are enrolled. So that information is all. So there's a lot of transition of care activities and transition of plans. What if I'm on the PHP today and I need to be on the tailored plan tomorrow because I got admitted last night to a psych hospital or a substance use facility, and that's my second admission in 12 months, which means it kicks me over here. How does that get me into the tailored plan? So it's a lot of that logistics, and it's going to be real important from a business operating standpoint that your front office staff are keeping current, or however you're doing your billing, how that process is going to work. So.
Same thing. This one is just more focused on the regions 1, 3, 5, and 6. The other 4 regions, a little bit different timeline because this one starts up in February 1st, 2020. But again, all of the same activities. And again, this whole piece that Tara was just talking about with the potential information going back and forth, that's going to be critical to understand how that's getting effectively done. There's still some glitches probably even to be worked out in that whole piece. But your folks staying on top of what your patient's enrollment is today versus tomorrow, that kind of thing is, you're going to need to constantly be keeping a pulse on that.
So for you as a provider, I need you to think back. So what typically happens when one of your members, one of the people you serve, gets a letter from the state or a letter from anybody else? They bring it to you. First of all, did they get it? Because the address is probably wrong at the DSS, right? Or they've moved 12 times. 2, did they open it? And 3, if they opened it, do they understand it? And because, you know, anything that comes out like this has had 900,000 lawyers look at it, and it's, even though it's supposed to be person-centered friendly, it's legalese. And so, heads up as a provider, be prepared, because they probably are going to say, or you delivering therapy and supports to that individual could say, hey, you know, I understand the department, you know, the people, your Medicaid folks are sending out some letters. Have you gotten a letter yet? Would you like me to help you read what that's a meaning about? You feeling good about what you're doing, or do you need any support? So a couple of provider agencies that we work directly with that are big, they work pretty much a big chunk of the state. They're actually going to open up some call center as part of their, just kind of do some one-on-one training with some of their staff, and they're big enough that they can have a call center, if you will, because they do it for some other stuff. So they were just going to add that in. So.
One more time, here is another visual of the 6 regions, another recap about when those regions are going to start. A little additional information on what is managed care, who's in, some of the beneficiary aspects, et cetera. And again, we can't overemphasize the importance of understanding what's standard plan, what's tailored plan, what's still going to be fee for service. And Tara's going to take it up from there with some additional pieces.
I really am now.
Yes, you are.
So these are the services that actually will be available under the standard plan. And if you look, there's a lot of substance use services. There's a lot of substance use services. Peer support is actually going to no longer be only a B3. It's coming under the state Medicaid plan, SPA. So peer support is actually going to be a standalone with all the hoops you got to jump through, but it will be available. There are also plans to submit a family peer support. Still not yet about recovery coaches, have not been talked about yet, but I think you got some ways to deal with that. We'll talk about the substance use waiver here in a few minutes, because that's going to also, these are the existing services. With the substance use waiver, which gets into some of the IMD things we'll talk about, there's going to be additional services developed, and that because the feds, as a condition of approving that waiver, said you got to have services at every ASAM level. So there's going to be, over the next 2 years, additional opportunities. Questions, comments, making sense on how that's going to work. It's going to get interesting. So the reason they did that, because it was controversial, go figure, was access, to try to get people access to basic behavioral health and basic substance use services without having to go through as many hoops in terms of a small catchment area. Okay? So, what are tailored plans? Those are the standard plans. All the Medicaid benefit and these behavioral health services, right? If I got a transplant, if I need skilled nursing, if I need home health, if I need medication, MAT, it's going to be here in standard plan. Tailored plan is that specialty plan that says, my behavioral health needs are a little more complex than just some basic services. I got a lot of other issues going on. But to go back with that second slide where we talked about what whole person care is, it also said, you know, it's really hard if I'm dealing with my complex behavioral needs, but I'm also got my diabetes out of control, and oh, by the way, I'm on the heart transplant list because I've been a drinker for 50 years and my liver's gone and blah, 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 and I'm HIV positive. Okay? That person sound familiar? So they're putting all those medical services. So the tailored plan will be those individuals who have complex or more intense behavioral health needs. And the LME MCOs, in addition to managing that, will also manage their medical. Okay? So the legislation requires that they partner with a standard plan, with a health insurance. LMEs have never managed transplants. LMEs haven't managed non-emergency medical transportation. LMEs haven't managed hospice or home health. But the PHPs have. But we all know we don't want to segment, oh, you got to go here, you got to go there. So we're trying, the purpose of Medicaid transformation is to try to make it a holistic kind of management. The legislation says that the LMEs can have the contract for the first contract period. They go live July of 2021. Current legislation says you can have the contract for the first 4 years. After that, you must compete with whomever wants to bid on the tailored plan. Okay? Now, why is that important? It's important because legislation says that there can be no less than 5, no more than 7. There are 7 today. So the legislation actually says you can have less than the 7 today. It also said that you are guaranteed the contract. But it doesn't say that you're guaranteed the contract if you don't have the skills or competencies to do it. So they will have to respond to an RFA, a request for answers for February 2020. So they got to do, they've actually been told, and the department has said, that you pretty much are going to be looking at the same requirements that the standard plan. That standard plan RFP was about 1,000 pages. Okay, it was fun. It was fun reading. Only Medicaid geeks enjoyed it. And they have been working on reviewing, looking, because they've got to develop some of that same infrastructure that United, WellCare, AmeriHealth, Carolina Complete. They can partner, they can buy it, but they have to have the functionality. And it's got to be in place, and they've got to be able to pass a readiness review. All right? 5 to 7 regions. They don't map, they don't line up with those 6 regions. Okay? So part of, let's take VIA. Whoops. Part of VIA, because VIA goes all the way up here with Allegheny, Wilkes, Avery. Okay? That is in Region 2, which goes live in November. Taylor Plan doesn't go live to July 21. Well, part of the current population that's in VIA today comes out of VIA's catchment, out of VIA's responsibility, and goes into that standard plan. So what does that mean? VIA's population and their PMPM is going to be less as of November of 2020. Okay? So that's why we want to make sure you're staying in tune to, 1, which plan is the people I'm serving going to be in, because you may be used to billing VIA or Trillium or East Point, and if it's one of these services and they meet X diagnosis criteria, they're coming out of those LMEs and going in. If it's a tailored plan individual, they are going to stay right where they are under the BC waiver. They'll continue to just get behavioral health. Their medical stuff will continue to be fee-for-service until the July of 2021.
So one thing to be thinking about, if you looked at your population you're serving today, is based on the information you're just receiving, how many of them are going to fall into these standard plans? And that, that's kind of getting your head around that. It goes back to that whole piece we were talking about. Those are the ones you should really be focused on in terms of helping them understand the change that's coming down. If you can identify those are your target population to be looking at more closely right now, is that their service or their coverage, who's paying for their services, is going to change starting November 2019. And you're being able to reach out and touch those folks with more information, helping remind them of your services that you're providing to them today, how you're going to continue to have the opportunity to serve them, but yes, you're going to have to reach out and get contracts with these PHPs in order to continue that as well. But clearly doing some homework is an important part of this.
So under the Taylor plan, you get all those services that we listed under the standard plan, plus you can get these services. So people on the standard plan cannot get these services. So if I went and chose the standard plan, and then I came up later and said, I think I want to go to psychosocial rehab, I can't get it under the standard plan. It's not a covered benefit. And the only way I can get it is come over to the Taylor plan. Okay? So people under the Taylor plan can get everything under the standard plan, but people on the standard plan can't get the Taylor plan. Okay, am I confused? Now, your members are going to get that, right? Yeah, it's going to be hard. You got a question?
Are all of the services finalized?
So no, there's one of the substance use services is, is actually right now, SACOT's over on the standard, right? But there's question about SAIPs. People are debating on where that should be. And then also with the new services that are coming up under the ASAM for the substance use waiver, they'll have to figure out where those are going, okay? Now, significant is if you are getting state funds, Because the Medicaid population, obviously, as you guys know, in the substance use world is not as great. It's a limited. Those individuals are actually, if you are getting all state funds, you stay in the tailored plan, okay? Your contract or your services. Now, that's important because most of you, especially in the substance use world, most providers get funding from a lot of different sources to cover the cost. Your mix is usually a combination of a few Medicaid, unless you're a women or a children's program. If you're an adult program, you probably are getting a lot of state funds somewhere, okay, in addition to your other stuff. But okay, so clear? Make sense? So tailored plan design, and this is where I think is really important for you as providers. Conceptually, and the department is doing a really good job of keeping their website current on where things are. They're posting things up. There's usually, they'll do a presentation at a meeting or a webinar or whatever, and those notes and those slides are usually up the same day, if not within a day or two. I mean, they're really doing, yep, I'm seeing those expressions because that's not, they're doing an excellent job because they realize this is such a big transformation, right? So here are some webinars. We can change this. The webinar actually was yesterday. I don't know if some of you guys were able to participate, but they went over exactly some of that eligibility, who's in, who's out, how that's going to be talked about, what are some of the IT systems that they're trying to put in place to make sure that happens. These are some areas that are pretty big that the department has said, here you understand these are areas that could be real concern. We're going to put some more information or put some more time and energy on what that needs to look like. This design up here, this is what we're envisioning. Now, how do we make it happen? What's the operation? One of the most, in my opinion, the most controversial part is the role of care management. In the standard plan design is care management happens at the point of service. And the words care management, care coordination, and case management get used interchangeable. One of the questions here is the providers are saying, and the recipients and the LMEs are saying, define what you're talking about. Define it. Because the standard plan says it happens at the point of service through the advanced medical home, AMHs, and or other entities who've been delegated. You are used to care coordination happening at the LME MCO level, right? That's what you're used to, unless you are providing a service that has case management embedded to that service. Other than that, this changes that. This says LME MCOs, you'll have a little bit of about a care management function. There may be some specialty population that you do it for. Other than that, it happens at the provider level. But it's not about, if I'm seeing 4 different providers, my cardiologist, my outpatient therapist, my HIV counselor, I'm not having care coordination or case managers at every one. So it's not going back to the targeted case management days where there are 5 people going into that home and nobody knows what the other one's doing. It's still one care coordinator who's looking at everything, whole person care. They made a presentation of that design just earlier this month, and there's going to be additional discussion. So you're going to want to keep current on that website. A lot of providers love this. A lot of providers don't like it. LME MCOs, some of them hate it. Some of them are saying, I could see that to a degree for certain populations. Okay? The next item is health homes. And health homes is under the standard plan, AMH, the advanced medical home, it starts to define what that entity, what that provider does for that individual, so that there's a single place that kind of owns the care and supports of that individual, all right? In the standard plan, it's pretty much makes sense to everybody. It makes sense for primary care to do that, right? A little bit of behavioral health problems maybe, some ADHD, med management, some basic. A lot of discussion on the tailored plan on, does it make sense for primary care to be the health home when the whole reason they're in the tailored plan is because they have complex behavioral health, not necessarily complex medical. For some individual, it will make sense for them to be with the medical home. All right? So there is discussion going on what that looks like. In your world, there's a lot of providers that say that should be with some of you comprehensive behavioral health providers. You guys may be familiar with some of the stuff from SAMHSA early on CCBHC, Certified Behavioral Health Centers, you know, when they were looking at those criteria. A lot of people are saying that's what we want. That's what it needs to look like. And then there's the eligibility and enrollment, and then the network and adequacy. So all of that will be hashed out between now and when they go live in July 2021. But you got to back it up, because all those timelines on enrollment letters and IT systems, so you're probably going to have all this stuff decided over the next, my words, not the department, 4 to 6 months. Okay? This is your eligibility. So you've got those services. If you're on the innovations waiver, that's for IDD. If you're on the TBI waiver, if you're on the transition to community living, if you're on the innovations wait list, you're on the TBI wait list, you're on children with complex needs, and there's a definition. And they're going to be looking at these criteria. So they're going to be doing all this data dump from paid claims to see what the kind of services have been provided to that individual. And they will use both your state, they'll be using your IPRS funding, all your encounter claims that you've been sending in to the LME MCOs that have been going up to the department, and all the claims that are being paid directly out of NC tracks. And so this is going to be how it gets done. And they're going to do this on the entire Medicaid population. This is happening today. They are doing data analytics today. The LME MCOs are taking this information and they're running it against their current caseloads, and they're saying, my current PMPM is 100,000 people. Based on this, I'm now down to 12,000 people. And I'm making up those numbers. But that's the kind of analysis that they're doing, okay? So, we've been talking about substance use. Well, let's talk about it, because substance use, like many behavioral healths, are about a family. So I am a family member. Let's say I'm a family member. Let's say me, Tara, meets the criteria to be in a tailored plan. All right? My husband, Jeff, is also on Medicaid. He doesn't meet the criteria for this. So that means Jeff's in a standard plan and I'm in a tailored plan. What does that mean? It means we have two different benefits, and we have 2 different payors. So for a family, again, you can see why that care coordination, being able to know what's going on with the family if you're really trying to do systemic family systems, knowing how to treat and who's the payer, you've got to figure those pieces out. So some questions for you as providers: what is your funding mix today? Is it a combination of Medicaid dollars or state dollars or third party? Many of the substance use providers are doing third party Blue Cross Blue Shield private insurance if you're individuals. But it may be the dollars that you're getting from Aetna's private pay and Medicaid and everybody and X, state funds, putting it together is what making that whole, right? So you need to figure out what's that blending. So from a strategic analysis. The other thing you need to think about is, where do my individuals fall? Are they a standard plan or are they a tailored plan? So it's funding, and then the second item is about individuals. The third item is, what's your region today? What county are you serving? Where are your individuals being served? It is based on county of eligibility, where that Medicaid eligibility, what that address is. So let's say that I live in Murphy, North Carolina, Macon County, which is in Region 1. Region 1 goes live in February of 2020. But I got sent up there from Wake County, which happens, right? In substance, you got people all over the state. My eligibility is in Wake County, which is Region 2. Region 3. Can't even remember. That means I go live November of 2020. So even though your facility may be located in a region, the payor may be in another region. Does that make sense? Another thing your folks are going to have to be attuned to. The other piece is, which is a pretty big item that Gary and I spend a lot of time talking with providers, and that is whether you are in a standard plan or whether you are in a tailored plan, there are going to be, it requires data, it requires advanced payment models, and it requires some alternative or some outcomes. And you're going to hear a lot more. I know you guys, some of you go to the Eye-to-Eye conferences and the Pinehurst conferences and your APNC conferences and conferences in the NC Tide, and you've all heard about value-based purchasing. Probably until you're sick of it, right? Well, in Medicaid transformation, the time to be sick of it means that it's time that we stop practicing and it actually starts to get implemented as requirements. So in the standard plan, and it is expected there will be some of the same in the tailored plan, there will be requirements, and this is what's actually written in the standard plan. It says by the end of contract year 2, which would be, they go live in November of 2019, by 2021, they've got to increase their contracts, their provider network, by 20% who are in value-based purchasing arrangements, and 50% of their total expense, or 50%, or and, is it an and? It's an or. 50% of their expenditures must be based on value-based. So they got to get less out of the fee-for-service, head in the bed kind of approach, whether a person gets better or not, to actually paying for outcomes, all right? It is going to be the same thing in the tailored plan of some degree. Some of you may have already started filling it. It's the same sort of thing that happens in the Medicare space over a period of time. You probably starting to fill it some under the 1915 BC because the state has put timelines must be seen within 7 days, for example, right? If the state has they have a percentage that if certain amount if that doesn't happen, DMA or North Carolina Medicaid can find the LMEs. Why is that going to be important? Because who as a payor am I going to want to contract with? I'm going to want to contract with providers that can help me, right? That can help me meet my HEDIS measures, that can help me meet my CMS adult core indicators, who can meet the child indicators. So what is level 2 and level 4? Because this is what we're talking about. Right now, most of you, I would guess, are probably category 1. Even though you're in a managed care environment, you deliver a service and you get paid. As long as you're meeting the regular Medicaid rules, it doesn't matter if the person gets better. And I'm not saying it doesn't matter, but just from a payment standpoint. Person could go to the emergency room 20 times. As long as you've provided the service that you are contracted to provide, you get paid. Under category 2, it takes this, but it starts to build on, you know what? Not only do we want you to provide the service, we want you to tell us what's happening. We want you to start building an infrastructure so we can get real-time data from you. We want you to be able to do reports when we ask you. We want you to be able to send them to us. And we want to be able to pay differently for those of you who are doing bang-up jobs. All right? Bang-up jobs. But guess what? We also don't want to pay the same rate for those who aren't. So you start talking about rewarding for performance and penalties for performance. Some of the LMEs today pay different rates if you're doing enhanced outpatient versus outpatient. If you're doing open access versus just a regular appointment. If you can get a person in within 6 hours versus it takes them 6 weeks, right? I'm seeing some heads shaking, so you're starting to see some of that. That starts to lay the foundation for category 2. They probably haven't started saying, oh yeah, is that open access producing better results for them than it is that one over here? That's just not, you may be seeing them faster, but are they getting any better? Okay? Category 3 builds off this, off category 2, and says, you can report, you got infrastructure. Whoa, hey, I'm saving a lot of money because you're starting to do. I'm saving a lot of money at the payor. And so the insurance company, PHP, Standard Plan, Tailored Plan, says, wow, you're helping me. Let me give you a percentage of my savings. You helped me. You actually did programming on substance use, but at the same time you were working on their diet and got their BMI down and got their A1C down on their diabetes because you're actually doing recreation when you're talking to them about their substance use disorder. Okay? So we're going to give you a percentage of our savings. But then they can come around and say, you're also, people from your agency are costing me money. You tend to send everybody to the emergency room. Your people, it depends on how you measure it. So they may say, you're going to pay us back. Or we're only giving you part of your payment, and when you show us this, we'll give you the rest. So you have withholds, you have some partial payments. There is some of that going on today on a very small basis. Okay? There's one provider in North Carolina that I'm aware of right now. I mean, there's more than one, but this particular provider has a deal with an LME MCO that, and he gets an enhanced rate for what he's doing, using an evidence-based practice. And if that individual goes into a higher level of care within X number of months, it may even be a year, then that provider has to pay for that cost of care. He doesn't provide that level of care, but if it has to go because it is, and Gary will get into why and what you have to have in place. If you are a small provider, you need to be cautious about this, and you definitely need to be cautious about Category 4. Because that Category 4, they're going to say, you got 10,000 people, which some of you do. You're a big provider. They're going to say, you know, here's $100,000 serve the people. All right? But it's a different kind. It's a different kind. It's subcapitation arrangements. Right? Now, these are some that are in other states, some of the examples, and I know these are going to resonate really well with you guys. Some of the LMEs, some of the PHPs that actually have won here in North Carolina, these are some of their payments, some of their incentive payments that they're doing. Now, they're doing HEDIS measures, they're doing core indicators, but they can also pay for different outcomes. They can do pilots. They can do all sorts of different things. So employment. And think about it in terms of substance use. If my substance use treatment and supports is being successful, wouldn't one think I'm maintaining my job? Or I've got a job. Right? So it's not that I provided 20 units of SACOT. That's that Category 1. When I provided 20 units. What Category 3 is, yeah, I provided 20 units of SACOT, but I also assisted that person through my supports, through my care coordination. I got that person maintain his job. All right? I also was able to participate in community activities, meaningful community activities. Not we all loaded up in the van and went to feed the ducks with everybody I live with at the treatment facility. But it's a meaningful activity, okay? Now, I'm being somewhat sarcastic, and I appreciate that, and it's not meant to be offensive, but we're trying to get you to think in terms of how it looks different under Medicaid transformation and what that whole person care looks like versus what we've always done, and why the department went with that 1115 waiver instead of just leaving things alone under the BC waiver. Because you don't need 1115 waiver to do managed care. It's all the other stuff that causes that. The other is integrated housing. Having stable housing. This one should resonate really close with you as a substance use provider. Talking about reduction of criminal justice activities, either in the system, meaning, do you know when Tara's going to get released from the county jail? And do you have services in place the day she gets released? Because if I wait 7 days to get services in place, what is the likelihood of happening? Right? And so I'm measuring reduction of the criminal justice, But the strategy is making sure services and supports are in place. Okay? The other place is the reduction of churn. You guys know what churn is? Churn is when I go on Medicaid, I go off Medicaid. I go on health choice, I go off health choice. I go on insurance, I go off. The number one reason people lose their Medicaid has absolutely nothing to do with getting a job. Somebody forgot to send in a piece of paper. They forgot to sign something. And the reason this is important is because if I keep somebody on Medicaid, the likelihood of me continuing to get services and support, because I'm getting care management, remember? I'm checking base with you. Hello? You know, doing okay? What's happening? Mind if I stop in? Or even better yet, knock, knock, knock. Oh, I didn't know you were stopping in today. All right? Several providers in today's world have changed their front desk procedures and processes so they keep track of when their Medicaid terminates. And about 60 days before that Medicaid goes live, they start reminding and talking to that individual and supporting them. Now, have we got all our receipts together? You're ready to do this? You're ready, blah, blah, blah. You need me to help you? Okay? Because when a person goes off Medicaid, they usually don't get back on until they need care, which means things are probably worse than what they had. And they usually don't. It usually happens when they show up at the emergency room after not having anything for months. And it's usually the hospital finance people that are getting that Medicaid back in place. Okay? Decrease in inpatient readmission and readmits a period of time. Decrease in ED visits, primary care visits, and preventive care services, and monitoring and follow-up of conditions. Okay? If you are a SACOT or a SAOP provider, tell me one of these that doesn't fit what you should, could, woulda, shoulda, woulda do. All of them, right? All of them. The department has been very, very transparent on what their measures are. They are right there on that website. They actually, and if a provider and a SHP, a standard health plan, they're probably saying, when you are talking with those about your contract, about your rates, if you had some data to be able to say, guess what, AmeriHealth, my ED use of my clients is 0. Oh, sorry, mine's 80%. Too bad. So what will you be able to do? How can you make yourself more marketable, and are you able to prove what's happening? So here are the measures. Some of them have pretty significant paybacks and withholds. Some of them are $5,000 a day. Some of them are $100,000. Some of them are $150,000. So we're not talking petty cash. Now that's between the state and the payor. Okay? What the PHP, the standard health plan, does between you and them will be different. And it also depends on whether you're a Category 1. Goes back to where you are. Are you a Category 1? Because Category 1 is just your basic fee schedule. Or am I a Category 2? Or I'm a Category 3. Do not expect that all of you in every situation is always going to be down here, because you won't. You won't. Some of you are saying, I never can get here. I just want to be here. Well, eventually they may say, guess what? Because I got to increase my percentage over a period of time. I got to increase by 20, and I got to increase by 50. So if all I am is here, by year 4, what's the likelihood I'm going to want to keep using you? I'm starting to go down. Okay? Now, in 2 days, 1915 BC waiver. These are some, this is not an exhaustive list, these are some of those outcomes that that NC Medicaid is holding the LME MCOs to. So they're starting to hold them accountable in the same way that those plans are. So if you haven't started feeling it from the LMEs, but that's the reason why. Because one, they're trying to demonstrate their competency to the department in that RFA that they're going to have to do in February, that they've got some infrastructure in place to do performance-based, but also to start pushing you guys to get ready to do that as well. And these are the things: access to timely care, emergent, urgent, routine. Even though you may be doing that, you're used to that, now there's going to be financial penalties from the department to the LME MCOs for not meeting it. Penetration rates, how many people are being seen based on your population. If the typical penetration rate is 1,000, they're using them based on 1,000 or 10,000 rates. Why come you're seeing less than what the national average is? So they're looking at what you should be who should be seeing and by whom. Admission rates, initiation of substance use disorder services. We know if you're not able to start services the day the person shows up, the likelihood of them hanging around. Crisis care and emergency rooms. Emergency readmission rate, community hospital readmission rates. What's one of the biggest reasons, the two biggest reasons for readmits? Two biggest reasons is transition services not in place at the day of or within that discharge, and that's whether it's medical or whether it's behavioral health. And the second is med reconciliation. And not, if I got put on the hospital when I was in the hospital on the meds, I don't have them in place when I get discharged, I don't continue to take them, or I start taking those ones that I had sitting underneath the corner of the bedroom table and I never told the doctor I was taking them. None of that ever happens. Right? Two biggest reasons: transition services and lack of med reconciliation. What can you do as a provider to address those outcomes? So that's where we got to think, and all that has implications on what you do and how you do it.
So just to kind of continue that piece that Tara's talking about, we're really starting to ask and suggest you need data. You need to understand everything we just talked about, because that isn't how do I keep doing that? You need data about all of this information that she just went, all of these, anything that you can understand from your own information about how you're performing in any of these areas is something that needs to be measured.
And I would say, going back to that, part of that data doesn't mean that you go and you have to do a hand check of your 9,000 records before you can get that report to prove it. So it's about timeliness of data and access of data and ease, because doing something manually may cost a whole lot more than doing it electronically. Okay? So think about that.
Yeah. Readily available information is critical here, so that you're beginning to get a foundation established, some level of where you're starting from, so that you're doing management of the services. You're able to continue to monitor. You're building out dashboards for reporting that information. Again, it's just an ability to manage your business. It's an ability to communicate with the PHPs as well. I mean, because when they're talking with you, these MCOs, when they're talking with you, they're trying to understand what you do. And as Tara has been clearly stating, they want to know where your value is to their network. If you're not showing value to, I mean, initially they got to take everybody. And the only distinction is going to be, are you going to sign a contract with them based on the rates or whatever? I mean, you have that choice, but they got to offer it to you. Now, down the road,
if you're enrolled to NC Medicaid, they must offer you.
right.
Whether you have a contract with Via, Trillium, East Point, if you are enrolled with NC Tracks, they must offer you a contract.
But clearly, at some point, that will not be their, they will not have to make that choice. And as Tara was talking about over there in that category 1, if you're just trying to stay in that fee-for-service model and you're not moving towards any of the more outcome-based, value-based choices, they have the choice to they'll start narrowing networks. And you're going to be out of the business, to be real candid. You're going to have to, and it's also a competitive factor for you as well. I mean, some of these things that if you're successful in accomplishing, and some of those that you're competing against are not successful, then that's going to put you a leg up, help you expand, build your market share as well. And clearly we're getting into the point of understanding where's our financial risk in all of this. Because that's a huge factor in your sustainability. It's a huge factor in you being a reliable provider that they can count on when they make referrals to you, or you're working with you on your referral network, etc. Anything else to add on that one? So now we're looking at, from the financial aspect, we need to understand direct cost and indirect cost. Direct costs are the key elements of providing that service. The individual's salary, their benefit cost, are there some transportation factors, mileage, are there some supply cost, are there some contract relationships that are related to that particular service. So we're trying to get back to a service item and a unit that's easily measured so that we've said, okay, this is our cost for that, this is the units that we provide of that, and now we know a direct cost per unit. That whole conversation can lead us to looking at rates that we're willing to accept under fee-for-service even. Are we getting a payment that's at least above where our direct costs are? If we're not, then we should, the red flag should be going up and saying, what are we going to do different going down the road? And is there some other creative way? Should we start looking at choices around the bundling? Or are there things that we can package together differently that allow us to be more successful, even though right now it looks like we're losing money on this particular service line? Are there something else that we can put with it that we're going to make money, enhance payment, whatever it is? How do we bring that forth and package it in a way that we can sell it to the PHPs or whoever as a way to enhance what we're doing, what they're doing, bring value to it, that whole conversation.
So if you go back to slide 18, that's why we asked the question, what is your funding mix today?
Right, right.
What is your funding mix? Okay.
I know some are not even in the Medicaid world right now, but some of these fundamentals are clearly needed to operate your business even in the non-Medicaid world. With private insurance contracts, with Medicare Advantage plans. I mean, there are a whole plethora of payers out there, and we're adding a whole new mix to that. But it's a critical piece to understand so that, we're getting, and again, we're trying to even look at on a per patient basis. What are some of the costs that we may be incurring if we just looked at number of patients? Because one analogy, for example, if I wanted to come to you and negotiate a per member per month fee, and I know you're serving 5,000 individuals on a monthly basis. And I know it's costing you $500,000 to serve those. Well, what do you need from me on a per member per month to serve that population of individuals? It's a minimum of $1,000 per member per month to serve that population. So those are the kind of choices. Even without data, we can't even articulate that effectively to somebody else. But at the same time, we can't even understand whether we can make money on it or not. And let me not get confused here. Even if you're in a nonprofit organization, you still got to have a positive bottom line to sustain that organization, correct?
No moolah, no mission.
So it is an important piece as we start thinking about the indirect cost. That's our overhead structure. That's the people that are in the back office. It's our HR people. That's a lot of infrastructure that we need to make sure we've layered that into any of these cost computations, and some margin, some reasonable margin above our direct and our indirect. Some reasonable margin is where we need to get to in our pricing.
What's a reasonable margin?
Well, in the Medicare world, which is where my background is more comfortable with, Medicare has historically said, okay, you know, hospital organizations, if you're in that 5-6%, we're probably okay. We're not wrong. It's once you go into double digits, above 10%, then Medicare starts getting all squirmy and wants to cut your rates, and they go back to, you know, Congress and say, you know, you need to whack this one.
Well, and that's the same sort in the Medicaid space. That's where you saw the MLR, the medical loss ratio. You know, in the federal regs say 85% should be service and 15% should be the overhead. So in the General Assembly, North Carolina's legislation, it said the MLR is 88%, which means you can only have, for the payors, now for PHPs and for the LME-MCOs, they can't have more than 12% in that overhead, in that administrative. You know, and that's where I was going with some of your stuff, was because Gary's given a very high level of indirect and direct. And when he just mentioned, for example, that backroom function kind of stuff, well, let's back up to one of those outcomes I just said, and that's to reduce churn. Well, maybe that backroom function never has been checking Medicaid eligibility. Maybe they've never done anything. They're not even logging into NC Tracks to see, or NC Fast to do an eligibility read to see if they're eligible today. If that starts, and you start doing that, then you start looking at, okay, that productivity is going to go down a little bit. I got to either add staff, or I either got to add some technology that automatically does it beforehand. And so what you may want to do is start figuring, okay, how do I get it more on the direct side rather than the indirect side? And how does that play out? And the federal regs have some pretty good guidance on how you can play with that. But it's important to be able to think that. It costs me, you know, it costs me X dollars to get somebody in with 2 days. It costs me X dollars to get them in within 7 days because you got capacity. So that's kind of where you have to be thinking about, one, what's going to pay the biggest rate, where I am today, and what do I got to do to get to where I want to be. Because if I'm going to be a level 2 or a level 3, I got to know that stuff. In Gary's example about that 1,000, in just that makeup example, if I'm getting paid $1,000 because my cost today, or this, is $1,000, but guess what? Every single one of my individuals are pretty much in that high level, complex, going to need a lot of hand holding, high touch case management. if I don't know the difference between those kind of costs to serve that individual and the cost that just says, I can call Tara and she's fine by just calling her up or sending her a text that says, don't forget, got to come to your appointment today, versus me having to go out and say, I'm here to pick you up, Tara. Let's go into treatment today. Let's go into my outpatient service. It's two entirely different costs that need to be, and that's where when Gary was talking about this, that's what he's getting into. I had a provider where I said to a provider, what's your cost? Yep. One of these providers that you guys would all know in the room, and you would think they're a great provider. I mean, they do good work. And they said, well, I get paid. My rate with, I said, no. What's your cost? No, I get paid. I said, I know. What's your cost? Because guess what? If your cost is less than what they're paying you, are you doing payroll to payroll, paycheck to paycheck? What happens when VIA or Trillium or Eastpoint or NC Trax goes down and you don't get paid for a week? Right? They said, well, we'll just provide more service. I went, if you're losing money on one service and you provide more service, that just means you lose more money.
The other piece that she's touching on is working capital. That whole delay in payment builds out AR, accounts receivable. Have you got reserve somewhere to sustain you through that period? If you're operating week to week, you don't. But again, that's where we've got to get to, though, as we look futuristically. How am I building out some reserves? Because I need those reserves for other things. I need those to make investment into just computer equipment, software applications. Training. I mean, that, you know, some of those are operational pieces, yes. But some of them are, you know, fundamental capital investment. And if I'm not making money somewhere, I will not generate that kind of working capital to have. I will not have those kind of reserves. And be cautious here if you're taking on debt to finance working capital, or taking on debt to finance equipment or facilities. Can you pay that debt off? Are you going to have that cash flow in the future that's going to retire that debt? So those are some other critical elements that we're admonishing and working with clients on and in that context.
And that's the other reason, too, with the cash flow, you're used to getting paid how often? You get paid weekly. LME MCOs pay you weekly. So now you're going to have different payors. Could be paying the same time. I'm not saying they're not, but you just need to be aware that those kinds of payment, again, based on your funding, because you're no longer just with an LME MCO, unless you choose that. I mean, I'm not saying.
But in the RFP, they gave the PHPs 30 days that they had to.
Right, they did. Which we've all said, if you go to 30 days, you guys are going to die. Because all 70,000 providers in Medicaid are used to getting paid weekly. Even if you're on fee-for-service, you pay NC Trax, you know the check write schedule. Yeah. Okay.
So again, we've talked some about, again, the importance of understanding where our current rates are, what incentive payments could be, how do we begin looking at, as Tara talked about, one of the choices in that model of 4, how do we begin sharing in the savings? If we are, I mean, not only are the PHPs potentially offering it up, we've got to be proactive in going to them and saying, by the way, if we work on this bundle and this is the fee I'm asking you to provide to me, I know you're going to be successful. And I'm wanting another carrot on top of that. And you've got to have the information help them understand how you do bring that kind of value to them and be able to share in the savings, or if it turns out to be a loss, how you can take on some of the loss. Non-traditional services, and again, Tara's going to talk a lot more about the social determinants of health, some of the things that are coming down the pike with additional funding that would help out in that regard.
So I would just say, in lieu of and the social determinants of health, Gary and I and members of our team have been in rooms with contract negotiations, or when the PHPs have actually started talking to providers. And so far, I have not been in a single meeting like that where they haven't started talking to these, that they haven't already started saying, what can you do for me and what can I do for you? So it's already happening.
So again, the opportunities, once we understand cost, being able to help us move to any of these advanced payment models, be able to take on risk. Clearly, we got to be realistic as to what that risk that we can take on. Understanding how to track averages of cost of services by level of care, use of the data to develop these value propositions that the PHPs, they're going to do a readiness review before applying for some of their APMs, but again, we got to help them understand what we can do. Exploring partnership opportunities. Organizations that are smaller entities, but they've got kind of a niche because of the geography they're in, or the niche because of the service they bring to it. Are they organizations that could partner with larger entities and be still successful? There's some choices there to make. Some networks maybe can be developed. But at the end of the day, too, part of this whole strategic review of your organization is to try to help you understand, am I sustainable? Can I be of value and be successful? Or do I need to be thinking about merger and acquisition, selling, becoming something bigger? Those are important choices, and especially if you're my age and you're running an organization, you're also thinking about your personal succession plan. I'm wanting to retire, and I'm not willing to take on more debt to keep this thing going. Is there somebody else out there that I need to be talking with that may be more excited about their longevity than I, et cetera? So, I mean, those are the choices that we're kind of getting to here with this opportunity as well. Efficiency, EHR, we haven't really touched on that much, but that's an important piece that every organization is going to have to be able to network in and get involved with the health information exchange, that kind of communication piece. And again, that's another cost factor. If you don't have the right health record system today that allows you to do all that communication, you're going to need to be investing in it. Or I'm going to be reaching out to some organization that I want to partner with that can help me get that EHR that I need.
That I can just piggyback onto their EHR,
right,
and not have my own. But
is there a clear leader right now with behavioral health and SUD EMRs?
No, and the reason why, IDD pretty much uses TheraApp, and then you've got Patagonia, you've got Epic and Cerna, or you got the tip. Then the reason why we're saying that is because, remember, some of those EHRs for behavioral health, they were like just behavioral health. They weren't even able to come in and capture stuff from primary care. Well, it's sort of like, if all you're doing is my SU services, you're not going to be helping. You got to be able to do the exchange. Most of them have the capability. It's just they hadn't been marketed. You didn't buy that packet. So there's a lot of that. And then there's the other side where the medical, tended to have some basic, they didn't have those really intensive services like for for SACOT or something. They'd have an outpatient behavioral health, but they didn't have a more intense. So, but the one thing I know about IT, if it's a market, they will develop it, and it is massive. It's been developed a lot. It's a lot. We got about 15 minutes. So.
And I'm going to
Yep.
need to slip
Okay.
out, but I hope all of these things that we've just gone over have been some real practical tips. We would encourage you to be thinking in that context. And Tara's going to take us on home. Thank you.
So where we're going is, obviously we're moving to a system that's looking at revenue based on value, not on the number of units or encounters you provide. So if all you provide is, and I love it when people say, well, it's just widgets, heads in the beds. If that's all you're doing and you're not providing the quality, especially when you go back here, if I can buy it, if I can get people into a provider agency within 2 days whose cost is lower than the agency, even though you're the best agency in the world, and you can get them in 2 days too, but guess what? Your costs are $100,000 more than what that other agency is. You just lost your competitiveness, right? Right? All right. So, trying to be proactive and predict. I tell providers time and time again, it's like, guys, we've been talking about this stuff for years. We have been talking about it. I have pulled out slides that I've used 5, 10 years ago and said, guess what? It'd be here now. It's really here. We told you, we told you, we told you. They're looking at quality, efficiency, satisfaction. So trying to make those things happen. So discussion points for you that I think is really important. And one is about opportunity. Substance use providers, you are some of the most innovative and creative ways of getting your services out there and your costs covered. I mean, and lots of times your infrastructure has not been there because you were trying to get by on pennies. And you got in because you wanted to support people in recovery, right? So there is a lot of opportunity for you to integrate with primary care or medical providers. Do you have provider referral patterns? Do you know what doctors your patients, your consumers see? Do they all go to the FQHC? Do they all go to Wake Pediatrics? Are they all going to the health department? Are there opportunities for you to partner with them to do some specific activities to help on those HEDIS measures, to help them get some of there? If you're in the child business, there's a big act called Child Family First Act. That's in the child welfare. That's a federal law that's been passed, that the state's having to change how the 4E dollars can be funded to pay for congregate care and that sort of thing. And it specifically requires things about substance use disorders and mental health treatment. So, and the child welfare with the DSSs, that whole reform effort. There could be a lot of activities that you could actually start going in that you haven't been involved, you haven't been thinking about. But remember, slide 2, it's all about everything about that person. It's all about that person. Raising the age. Those are those JJ kids where that got increased. That's showing an increase in substance use and mental health issues. So if you haven't been dealing, we talked some about the help home. or the AMH, AMH standing for Advanced Medical Home. What level are you going to play in that? What's your role? Do you know who the AMHs are in your population? Do you know if they're a Category 1 or a Category 2 or a Category 3? And payment reform. We talked a lot about that in terms of predictable futures. I know that's probably a laughable statement in the mental health substance use world. But it is. It's pretty much nothing's happening in this state that's not happening nationally. We're actually probably a little behind in some of that. The other thing that we want to make sure, and that goes into the eligibles, is making sure that individuals know what they're eligible for. We find that most individuals, most providers do not know all the public assistance programs that exist. They don't know, and that's why they're putting into place NC 360. Okay? Our company just did some training for all the care coordinator staff and call center staff with 2 of the LMEs, and 4 provider agencies that just said, come train our agency. And it was like, this is how you get Medicaid. This is what you really have to do. This is how you get food stamps, F&S. This is how you get LIHEAP. And it was like, what's LIHEAP? Low-income energy assistance. This is how you get daycare. This is how you get all part of the system. Because remember, that's social determinants. The reason we started out providing training the providers within the LMEs, and some of the staff came to the training and they said, we want every single care coordinator to get trained. And they trained every care coordinator because they didn't know even some of that. Because if you're not doing it, you don't know, right? So, social determinants of health. You guys have probably seen some of that. The department got $165 million. That's not petty cash. Of the 1115 waiver to actually address social determinants of health. All the PHPs, regardless of the pilot, all PHPs, the standard health plans and the tailored plans, as part of their process, will have to conduct screenings for non-medical. They got to do screenings on where do you live, where do you work, did you sleep last night, what did you eat yesterday, all those things that we typically have not paid attention to. But we know it will make a difference. And NC Care 360 that's a new coordinated network where you can log in and find out somebody lives in a food desert, and these are where you can go. That's where your food bank is. This is where the food shelters are. And oh, by the way, the Baptist Church on Thursdays serves free lunch. Okay? So those kind of activities. And then talk about some of that in the pan. So that happens regardless. Everybody has to do that. In addition, this is $165 million that there will be 2 to 4 pilots that are implemented that will focus specifically on housing, food, transportation, employment, and personal safety. So they just recently, if you haven't seen that, that's there. Webinars were held in February. RFIs were submitted in March. And then sometime in late this year, the department will issue an RFP where people will have to formally apply. It is a community. It's not a single agency. Somebody becomes the health entity, but part of the requirement is a network. So if you just send in something that says, hello, Tara Larson Agency is going to do everything, are you part of a health part? Are you part of the health? Do you have FQHCs? Do you have the domestic violence shelter? Do you have United Way? Are you all at the table? A lot of pretty cool stuff. My suggestion is you want to be involved in those pilots. If you look at the Medicaid population, we all know that substance use is a big part. If you look at the child welfare data, very rarely is a child taken out of those homes that substance use is not involved in some way. It could be that domestic violence is what got them out of the home, but it was because dad was drunk, all right? Or mom was drunk, okay? Another big piece, and I'm going to pick it up pretty fast, is the substance use waiver. You guys have probably heard about that. It's not a separate waiver. It's part of the 1115. It's building out the ASAM levels of care over the next 2 years. So my question to you is making sure that you are staying current on that whole process, because there are some services that are going to be new to the Medicaid space. For example, recovery homes. You know they've never been billed. They could never be billed in North Carolina. That is something, now it may not look the same way, you may have to make changes, but that is going to be a Medicaid billable service at some time in the future, okay? So really, really, really encourage you to stay all over that substance use waiver development, because it's not just about, most people kept saying, oh, that means the IMD goes away. IMD, Institution of Mental Disease, which is that problem that we've had for 1 billion years. If you were over 16 beds, you couldn't bill Medicaid. If you were over 16 beds between the ages of 21 and 65, you couldn't bill Medicaid. So none of the ADACs could bill. Your freestanding hospitals, Holly Hill, could only bill for kids, couldn't bill for... That's what that was about. That's got lifted for substance use under certain conditions, and part of was, if we're going to lift this IMD, which is really your highest level of care, we want all these lower levels of care so that we're preventing people from going here, because that's the only option. And we want to make sure there's transition services so that if you were in here, you're getting services so that it prevents you from coming back here as often as you might need to, or should not need to, because if you need to go, you need to go. But now, it's still got to meet cost neutrality. It's not like the General Assembly or the Fed say, oh, here's another $20 billion, go ahead and do it. It's still got to be within that Medicaid budget. So this is the slide that Gary loves the best, because this is Gary, the bean counter, and this is me, the poet. And basically what he says is, I'm the clinician that thinks everything should be done for everybody. They should all have stable housing, and we should do whatever the person needs to make them stay healthy. And then he comes over here and says, how are you going to pay for that? And I go, it's not my problem, that's your problem. But we kid, because these conversations, if you only got the bean counters looking at something, you get to a different place. If you only got us rose-colored glasses people, you get to the same place. So we say you got to do it together. When I was in Medicaid or at mental health, and the clinical folks came to me and they would say, we have this best idea, and it's going to do this, and it's going to... I said, what's the money look like? They go, I don't know. I said, well, I'll tell you what. You, the money people, and you, the clinical people, get in the room. Y'all come up with something, including what's it going to cost, what's the outcome, and what are the providers going to say, and who's going to provide it, and what kind of administrative challenges are going to be. All right? The same thing has to happen in your agencies. The same thing. So what we know, all of this, rounding it up, identification of needs in the community and developing the appropriate program and services that are going to be bought. I can provide the best service in the world, but if nobody pays for it, whether it's Medicaid or non-Medicaid, having an EHR and or a way to provide data electronically. Can't emphasize that enough. Even if the General Assembly pushes that timeline out, I guarantee you, you will be right back next year, 2 years, having the same conversation. And if I got providers that I need to get who can deliver the service at the rate that I'm willing to pay, who have an EHR versus those who don't, what is going to be the outcome? Okay? Several LME MCOs have already said, thou shalt have EHRs by X date, even if the General Assembly pushes that date out. General Assembly can do that. But the payers don't have to contract with you.
Are you seeing providers in other states who are already working with outcomes-based model capturing all the data they're looking for in their EHR? Or are they using other systems?
So it depends on what the data is. All the HEDIS measures, yes. All those meaningful day and all that, the answer is yes. Got them, yeah. Now, some of that, for example, do they have lab results? Depends on the kind of provider. So if they're expected or they're helping on the A1C, on diabetes, if you're a substance use provider, are you going to have the results of the lab? No. And nor do you need it. What you need to know is Tara's diabetes is out of whack. So what am I doing to support that primary care doc who is measuring? And do I have a relationship that says, hey doc, when that blood level reaches a certain level, you ping me so I make sure that my person ain't getting any salt when they're in this, or whatever, okay? That sort of thing. Being able to have sustainable funding and managing expenditures. P for P is pay for performance. VBP is value-based purchasing, okay? And that was that category 1 through 4 discussion that we were talking about earlier. Also determine the clinical or programmatic models that meet the purchasing. If you're providing, if the market share is, if there's an individual practitioner on every corner, you're not going to get the market share to actually be sustainable, okay? There's never going to be enough funds. So it's really making sure that you are delivering the kind of service that is needed in that area and that you are doing it in a manner that's efficient and effective and cost. And that we've talked about the robust data system, and we've also talked a little bit about the analytic process. That's usually a higher level. Some of you are doing it. Some of you are still just beginning to think, what does that mean? There were some, and this is a scary thought, but there are some, when you do analytics, you can actually start to say, based on these conditions, if this person doesn't get X, Y, and Z, I know they're going to lose their knee in 5 years. Or I know that the likelihood of them having a stroke just increased by 30%. Or if that person's not getting on an ACT team or something within that discharge, it's just a matter. I can look at the last 20 years and see, and then we wonder why something happened. It was like, it was right there. It was right there, it told us. But what our system has been is you only knew what you did. And many of the individuals we serve switched providers a lot. Or they went from you, but you used to be over here and they loved you, so when you moved over here, they transferred to here, but you never saw it. So there's a lot of continuity of care and transition of care that we've got to work on. Now, Some people talk to me about oh good, that substance use waiver means that we're going to have all these new people eligible for Medicaid. Nope. That just means that Medicaid can pay where they couldn't used to pay. It doesn't mean that the Medicaid eligibility. So I still got to meet one of those Medicaid eligibility category. I still got to be age blind and disabled, or I still got to be a child, or I still got to be a woman, or I still got to be a medically needy. There are like about 21 Medicaid eligibility categories. Okay? Now that I work from the private side, I can say this real easy. Advocate the heck for Medicaid expansion, okay? And if you don't want to call it Medicaid expansion, you can call it elimination of the coverage gap. And then you don't have to say Medicaid expansion. But the reality is, if Medicaid expansion was in this state, substance use disorders would be one of the most beneficial areas of Medicaid expansion. Many of you know Tony Mulvihill, bless his heart, from years ago, and I remember on many, many occasions he would walk up to me when Medicaid and he'd say, Tara, when are you going to make Joe Six-Pack eligible for Medicaid? And I'd say, when the feds change the rules. Well, the feds changed the rules. North Carolina didn't accept the rules. But in that particular case, I would love to have Tony Mulvihill still here for many other reasons other than to be able to say Joe Six-Pack would be eligible for Medicaid. All right? I think you guys do an APNC, you guys actually do a Tony Mulvihill Award, right? Yeah, yeah. Well, now you have another story for the Tony Mulvihill Award. Yeah, and he was wonderful. I love him. The other thing that you need to know is both the General Assembly, the House and the Senate, the House is introducing, just so maybe it might be like next week, something on Medicaid expansion. There will be work and community engagement requirements on that. If you want Medicaid, you got to work so much time. For your benefit, the exemptions and there's one that actually lists if you are in treatment for substance use, that counts as your work requirement. Yes! Right? That's huge. It's huge. Incentive, because I can get treatment and I can get it covered and get paid for. All right? The Senate version, on the other hand, they want to do work requirements for today's Medicaid population, not just the expansion population. So who knows where that's going to go. So as we close up, it's really important for a provider agency especially to take all this in consideration for Medicaid transformation or any kind of transformation and look at a strategic plan so that you know what you're doing today in a very realistic point of view and what you're going to be doing tomorrow. Starting to identify what the resources are, your action steps. Be reasonable. If it takes 1 year or if it takes 5 years, you cannot do it all. Keep the ship afloat and do all the strategic changing all at the same time. No PHP or tailored plan are expecting turnaround miracles. It's about making steps and making progress and doing it within an environment. So the 1115 waiver is here. It is a reality. It ain't going away, even though some of you may want to, because their footprint is here. And once you get in, it's hard to get out. The enrollment broker, the contracting, the network, providing a provider network for the standard plans is happening today. It is happening today. It is things that are going on with the enrollment broker, who is Maximus, going back to those letters. They go live 2019, phase 1 rollout, and then phase 2 is February. Tailored plan design papers are out there. So whether you're going to be just in the tailored plan or not, they're out there on the website. They go live July of 2021. both the standard plan and the tailored plan are going to require those value-based purchasing and alternative payment requirements. So regardless of who your payer is, you're going to have some of that infrastructure to go in place. So my recommendation is start taking the steps now. Some of you you may have heard me over the presentation say you're already behind. If you haven't started doing some of this, you're actually playing catch up. But don't wait. Get busy. It's not the end of the world. It's good stuff. I was telling some members of the department the other day that the 1115 waiver, and this is no joke, it is one of the most important changes in North Carolina healthcare in years, in a positive way. It allows such opportunities. It is amazing. One of the reasons why we didn't do it much earlier was because of all the complications and infrastructure and political. Those are gone now. Now, is it going to be complicated? Are there going to be hiccups? Is it going to be about operations and implementation? The answer is yes. Now it's time to make sure we're playing and doing as much as we can in order to find out what those hiccups are. Some of it's predictable, like those letters. When those letters come out, we know the people we serve are going to have a lot of questions. And they're going to come to you. They're not going to pick up that phone call and call Maximus the enrollment broker. Some will. Okay? So thank you. Questions, comments, anything we can answer for you? You have our card? Yep.
How will the transition impact providers who are enrolling in Medicaid or getting a Medicaid provider number for the first time? I mean, like, I know like some of the LMEs are saying that they're not going to talk with any new providers at this point. Will that process change at all if I'm approached by one of the PHPs?
So remember that your enrollment with the LME MCO has absolutely nothing to do with your enrollment with the standard plan. So you can enroll with NC Tracks today, and even if you don't have a contract with LME MCOs, if you get enrolled with NC Tracks, then the standard plans have to offer you a contract.
That's what I was looking for.
Yep. Yep. Now, if it's one of those tailored plan services, then you probably won't get enrolled with NC Tracks. But if it's one of those regular, that you're fine. Okay? Anything else?
Thank you.
You're welcome. You're welcome. Feel free to call us. You've got our contact information, and thank you guys for all your support and your help.